Hello everybody, good morning and welcome to this first of the breakout sessions for this second day. So how are you surviving? Have you got conference fatigue yet? Are you still enthusiastic, keen, inspired by quality? I hope there's not much reaction there, guys. Anyway, first of all, let's talk about the tweets. Okay, Dave, ready to roll on the tweeting? Okay, super. Now, who are our tweeting info DJs? We have Teresa and VG. Do you want to stand up there, guys? So they'll be monitoring your tweets. Yesterday, took a bit slow to get going yesterday, but by the late yesterday afternoon, we had fantastic Twitter feed. Really great questions. And do you know what, really? It enables those of you who are a bit shy about asking a question, a bit shy about standing up. We can get the Twitter feed, and these guys will ask the question for you. So, keep your eye on the ball, get tweeting. It really worked very well, and it works very well for our foreign outside audience as well. So we really look forward to a great dialogue here this morning. Now, Lucy and Kathy are starting off, and they promised to do the impossible. They're going to improve quality and save money. Now, they persuaded me that's not impossible, and all I had to do was sit and watch their show. Lucy's from the Intermountain, Kathy's from IHI in Boston. You ready to go, guys? Dave, are you ready to go? I'll hand you over to the team here.
Okay. Good. He's going to fix that. Okay, thanks. So I'd like to welcome everybody. It's a really large group today, and as he said, we're going to do the impossible. I wanted to, this says finding waste and optimizing cost. I really want to talk about and draw your attention to the second line there, which is very small on your screen, and it's clinical and financial partnerships, and they're really key to reducing cost and quality. How many of you are clinicians in the room? Okay. How many of you are financial analysts or work on the budget side of things? Great. A few of you. Whoa, good. Terrific. And how many of you wouldn't consider yourself either one of those? Okay, I'm not going to go through and say what you are, but tweet that in so we can tell what the other large group is. I'm not going to spend time on the objectives, but what we want to know is we want you to think about where you are in your organization or your unit or wherever it is you work. And we want to know if you're actually building infrastructure and getting the tools ready, if you're just getting started, if you're working hard in some places and you've got some spots of excellence, or if you're actually starting to think about systemically about extracting waste out of your system at whatever level your system is. It can be an entire region, it can be a hospital, it can be a unit level, it can be a clinic, it can be anything. And again, if you're there at that other level, and if you're just getting started or where you are, we want you to kind of hold that thought in your mind as we go through this. So what we've begun thinking about is at IHI is how to begin to blend this together and to begin to say, when we started talking about this, people would say, well, you're only talking about a hospital and you're only talking about the triple aim and you're only talking about, so we're trying to start to think about what would it look like if we pull this all together and say, what are the cost measures we need to think about? What are the utilization measures we need to think about? And what are the quality measures we need to think about to hold it constant? And if you look across your screen from left to right, you'll see the acute care, you'll see ambulatory, then you'll see a health plan. If you're in the US, it's Medicare, Medicaid, something like that. It could be a health plan or an employer. In the US, a lot of the work is employer-based. It could be a health system, it could be a region, it could be a trust, and then it could be an entire nation. And what are the things we need to be thinking about and keeping our eye on? So we're hoping that each of you will see yourself somewhere along this continuum. And we also know that health systems are also employers, and hospitals are also connected to larger systems. So we know that the edges of this are fairly ragged, and we understand that. But with each you see, there's a cost per something to keep your eye on. What we've learned in this work is we originally said, let's take $2 million out of our system. Well, we find out if somebody's working really hard to take out a lot of money somewhere, pounds or dollars or euros or whatever, somebody over here can be doing something else building buildings, reallocating, and you really don't have money coming out of the system. So we wanted to have sort of a balancing measure. So we start to think about cost per patient, cost per episode, cost per case. What we also really found when we started working deeply into this is that clinicians and finance think very differently. And those financial analysts think in terms of kind of spreadsheets and aggregate numbers. In the US, they think of kind of DRGs and ICD-9s, some kind of coding system so they can understand the patients. They divide things up into service lines. They think of payment streams. How are we getting money for this kind of patient? Return on investment. If we're putting in money, where do we get it back? Throughput, and obviously they're responsible for budgets, thinking about budgets, making budget. Are we ahead? Are we behind? Where are we? Clinicians think about patients. They think about charts. They often think about the worst case scenario. We can't do this because, and there's the worst case scenario that comes back out. All the complicating factors and the social factors that they deal with. And then they're thinking about outcomes. Well, if we cut corners here, what will happen over there? So what we have to do is begin to help these two groups speak the same languages. And the same language turns out to be speaking it around the patient. So we begin to shape partnerships that really look at collaboration between quality, finance, and patients. And what we find is patients don't fall into a nice, neat category, as you all know that are clinicians, and you all probably also know that are financial analysts, even though in those settings we try to put them into some categories. We also need to draw on the knowledge base and the expertise across both disciplines so we can begin to share this. And everybody needs to work with each other so we can understand how to take costs out from a clinical perspective, and finance can help us monitor it to make sure cost is really coming out and we're really getting the quality that we had hoped for. So one way to think about this is sort of in a value stream methodology. And you think about any patient condition, you're going to hear a lot more examples of this. And you start to just write a simple flow chart about the steps in the process. What does it look like? Where does it start? Where does it end? How does it fit together? Where might a patient like this with this condition go or end up over a course of a care, over an episode, or over a course of a lifetime? Identify your start and stop points from the point of view where you are in your system. If you've got control over this whole thing, great. Then make the model so you can see the whole thing and understand where your costs are. Then you need to set up a cost model step by step. What does it cost at an urgent care center? What does it cost at an emergency room? What's the OR cost? What does it cost inside of the walls of a hospital? What does it cost in the community? What does that look like? Then start to look for identifying waste at each step. This is one of our colleagues in the US, and they began working on a system of for community-acquired pneumonia, patients that get pneumonia in the community. The interesting thing about this is there was no way to actually describe the patients in financial terms because they appeared very differently. So they wanted to understand how to do this, and they were working together, and they developed their value stream all the way from home, all the way the points the patients could touch the system, all the way to when they were back in the community. The interesting thing is the clinicians were talking about the kinds of patients that could get pneumonia and could need care from the system. The financial folks were sitting back saying, we don't have anything that can develop this for you. But if you keep talking, I might be able to do it. So they describe the patients in terms of age, they describe some exclusion criteria, they describe some inclusion criteria, and the financial analyst was then able to take that aside and begin to build a model and begin to set the task of putting a cost to each of the steps where the patient might go. Now, the interesting thing is not only did they understand then the cost of caring for a patient with pneumonia, they also were able to understand that in their system, which they had not seen before, these types of patients, before they hit the doors of the hospital, made up to 3 contacts with the system first. They tried to get care somewhere, maybe in a physician's office, maybe in an urgent care, maybe somewhere else, and we missed it. They missed it each time. So this is a great model to begin to think about how you might be missing things in your system and how that might be adding to the care. So by the time they showed up in the hospital, they were much sicker than maybe they needed to be. Also found out that they actually weren't doing preventative care and wellness in the form of pneumovax vaccines for this patient population. The short story is they developed a series of projects. Were phase 1 in specific areas, the things they were going to work out. They developed a series of projects in phase 2 where they were going to work. Each stream was looking at it. Finance was holding it constant. They've, over the course of about 2 years, working only in one segment, not across their whole system, in one local area region, have been able to take out about $3.5 million just using this patient population, which is relatively small. But they're able to develop this model, and we can share it with you and others as to begin to think about how they're going to do this other places in their system. They used what they called activity-based costing, but not really, because everybody doesn't have a great cost system to understand this. So they were able to, by the clinician's description of what happens to the patients, the financial analysts were able to assign costs to the outpatient setting, the inpatient admission, the other things that happened, and what happened post-discharge and how they needed to do that. And they were able to decide within each segment where the costs were and what that looked like, and begin to work that as they were working their projects. Were they improving quality, and were they also reducing the cost? So there's some strategies for beginning to make this work as you begin to understand your costs and your quality and understand your patients. First of all, finance sometimes needs to walk through the clinical setting with clinicians to begin to see how the patients arrive, how they appear, where they're treated, what happens in their home, some other things. Some places they begin to establish kind of a business advisory group that works very closely with an assigned portfolio, which might be a clinic setting, it might be a group of patients, it might be all patients with cancer, it might be something else. Often there begin to be dual reporting relationships, so these subsets and units can work very closely together, but they have a home-based unit that they report to as well. And we need to always consider the patient and the family point of view, because that's where great learning takes place. That's where you learn that in the home this happened. Oh, we tried to do this. Oh, we didn't understand this. And that's when you begin to change the care. And often when you hear a patient or a family say, we didn't understand, we didn't know, we tried, think in your mind, cha-ching. There's often a big cost attached to that when that happens. It indicates, in many cases, a hole or a gap in the system of care. So there's a couple caveats that you really have to trust each other. I don't know if this is in the systems in Europe where most of you are from, but in the U.S. system, I've spent my whole career in academic medicine in the U.S., but I've always worked on the clinical side. But somehow, physicians and clinicians think the hospitals and the healthcare system has all this money. They have money, they're billing, people are paying them, and there's all this money available, and everybody's just kind of hoarding it. And there's this great set of distrust that develops between administrators and business people have money, and clinicians can never get anything that they need to take care of patients. When the two begin to work together and really are transparent about what happens to patients, where the money is, what really gets paid, there's a great difference in understanding and a great sense. When the trust builds, clinicians are sometimes the best people at finding out how to take cost out of the system and how to do this. And then it takes the right kind of mindset on both sides to be able to do this. Not everybody can think holistically. Not everybody can think in patterns in this way. Not everybody can see some of their clinical work as waste. And you'll hear more of that in the second presentation. So you need to begin to think about what you're doing if you're building your system or if you're beginning to extract waste out of your system. There's a couple of process methods that we're going to describe, and we're going to talk about financial analysts that are robust, that assure cost reduction based on specific patient conditions. And then we're going to talk about some methods and models to do this. And I'm going to turn it over now to Lucy, who will really take you down so you can actually see how this works on the ground. Thanks.
Well, good morning, everybody. I'm from Intermountain Healthcare. My name's Lucy Savitz. And for those of you who are not familiar with Intermountain Healthcare is a fully integrated delivery system that's based in Utah. which is in the western part of the United States. We have 22 hospitals, and we have over 185 outpatient clinics. And what I'm going to try and do for you today is to give you 3 examples of different financial models for trying to capture the cost reduction while we're improving quality. Depending on the time, I may get through all 3 of them. You will have all of the slides, and we're happy to answer questions later. But I think to sort of set the stage for this, irrespective of whatever your financial reimbursement or payment system is in your country, these examples are really germane to the work that you're doing. Because in the United States and in other countries in the world, it's really been sort of a volume-based practice. You get paid more for the more procedures you do, the more admissions you have. And that's changing. That's changing globally. And so right now, on a short-term basis, from a survival perspective, people are looking at ways that how do I expand my market? And people look at specific things like employer hubs, to have, if you live in a city that's an airline hub, to have a direct relationship with that particular airline, or if there's a major industrial employer in your particular community, having a separate contractual relationship with that employer to generate the volume that you need to continue to sustain your services under a volume-based model, or even looking at domestic or international tourism, which many of us have done. But long-term, the challenge in thinking outside of the box, as we're sort of looking down the road to see what's happening with cost-cutting and different payment models that are being experimented with, is we really need to rethink how we provide care, how we can sort of reconfigure the organizational structures that we've been currently working on. Many of you, I'm sure, are familiar with places where we've shifted things that were traditionally done on an inpatient basis to outpatient care. I was recently at the University of Iowa, and they've built a whole new facility where they've transferred their bone marrow transplant service from an inpatient acute care, tertiary care facility to an outpatient facility. So we're seeing more and more things that were, even 5 years ago sort of unthinkable. And then really thinking hard about how do we have to refine our cost and revenue centers to adapt to these new sort of systems of care and locations of care. So one of the things that we've been talking about in our journey working with many delivery systems internationally is this notion of that there are many different ways to develop the financial models. And when Kathy talked about this and the real partnership between people in finance and people on the delivery system side and building those trust relationships, the main issue is that the finance people never really see the dollars that the quality people suggest are associated with the savings of the improvements that they put in place. And at the end, Kathy will talk about this difference between dark green and light green dollars. But this is sort of a global strategy. I saw downstairs, for those of you who have not been to the exhibit hall, the NHS Wales has a wonderful publication that's available down there on improving quality and reducing costs, quality as the business strategy. And I really commend this to you. It has some examples in there and a great literature review that's available to you. What I'll try and do is again, work on 3 of these examples that come from Intermountain Healthcare and have been sustained over time, and I think really speak to some of the points in this particular paper. The first is the use of continuous positive airway pressure for neonates. And we really did this analysis looking at net operating income. What was the impact before and after? So if you think about these different models, this is the before and after or pre-post analysis, if you will. And basically what had been happening is that neonates that were in pulmonary distress, who were less than 33 weeks of gestational age, had been transferred from a small community hospital to a larger regional facility. So it required air flight transport. And what we saw in the initial year when we tested this was that the reduced rate of transport went from 78% to 18% in 1 year. And so this was a major financial impact, and again, savings that had been sustained. This also suggests that other stakeholders in the process might be researchers, because it was researchers that did the initial test of change that suggested that you could use CPAP in these neonates. And so basically on this slide, what you can see are the way that we calculated the cost savings. So before you see the amount of the reimbursement to the birth hospital for the initial stay, then after for the extended stay because the patients were not being transferred, the fixed cost of the transport staff was there in place. So there was actually a net loss. And then for the tertiary hospital where the neonatal intensive care unit was located, there was actually a large revenue loss. So overall to the delivery system, we lost money on this particular improvement. However, under new reimbursement structures, that won't be the case. And so, at an integrated delivery system like Intermountain Healthcare, we have some of the latitude to do the right thing for patients. There are other places in the United States right now that are based on volume where there are disincentives in our payment system, and that's really the challenge for us in the United States, is to reduce those perversities in reimbursement. So one of the assumptions that would be required for something like this to work is that the birth hospital does have the capacity to accommodate the increased patient volume associated with the more extended length of stay. Again, we used a pre-post implementation approach, for babies meeting these criteria who were transported, we just compared reimbursement before and after and what the impact was that. You could further this analysis from a financial perspective. You could look at changes in patient loyalty and patient flow because of the improved quality of care that was being provided. The mental health integration example, and I will tell you, if you're interested in this example and in mental health in particular, there's a session tomorrow, H2, that Pascal Briot, a colleague of mine, will be presenting on in much greater detail than I'm going to fly through right now. But basically, this is an important example for two reasons. One, in this particular paper, they say one of the major challenges is overcoming this hurdle that most of the examples that people give of where you improved quality and reduced costs simultaneously, that those really occurred only in pilot studies that were reported. This is an example where we've actually spread from initial 6 pilot study clinics to now implementing this in over 70 clinics across Intermountain Healthcare of various sizes, rural, urban locations. So it's a good example of spread. We also looked at the cost impact across a whole patient care pathway, which is another sort of failure in the literature that the authors in this report cited. So basically, at Intermountain Healthcare, one of the foundational ways that we drive evidence-based practice is through things called care process models. And care process models really take guidelines and create narratives and tools around those guidelines to assist in the standardized and reduced variation in how we implement those guidelines in clinical practice. And one of the ways we do that is through clinical decision support tools, information buttons in the electronic medical record, flags and reminders in the electronic medical record. And so basically what it provides in doing this is really sort of the standardized clinical and operational process for how we deliver care. And the sort of strategy we use in primary care is something called a Cascade Model. And so we have case identification, and we have a series of screening tools that we use so that we can appropriately identify the right level of care for the right patient, basically. And so through these assessment tools, you can be either categorized as somebody who has sort of mild complexity in terms of their mental health condition, somebody who has moderate complexity in terms of their mental health condition, and somebody who has severe complexity in terms of that condition. And so the idea here is to get the right care to the right patient at the right time. With this model, then, and the team-based approach to integrating mental health into primary care practice, not co-locating, but integrating into primary care practice, we can treat routine and both mild and moderate complexity patients in primary care without needing to transfer them outside of the system to other levels of care. And we've been doing this for over 12 years, so it's a pretty well-tested model. One of the ways that we look to evaluate what were the cost savings in terms of implementing mental health integration was that we did sort of a matched cohort comparison. So we picked a period of time, and because of the electronic data that we've got available, we were able to sort of create a matched cohort, those patients who were treated in mental health integration clinics versus those patients who were not treated in mental health integration clinics. And what you can see here is that basically, for those patients treated in mental health integration clinics, they had fewer ER visits. They did have lower inpatient psychiatric length of stay for those patients who had been admitted. They had actually, which surprised us, lower medical inpatient length of stay. But as expected, they had higher PCP visits, higher prescription drug uses. But because of the shift in where care was being delivered effectively and getting the right care to the right patient at the right time, the overall cost was lower in those patients who were being treated in mental health integration clinics. So if you look at the all cost column comparison there, we were able to take this data because it had been so carefully constructed to the health plans and actually get them to fund care managers in all of the clinics so that we could support mental health integration. So it really took that partnership with the finance team and the quality team working together to be able to create the data necessary to get the subsidization for the services that we needed. So this was a payer-specific analysis, and one of the things that we were able to show was a huge amount of savings that were associated with treating patients, and you can see sort of the calculations on this particular slide. I'm not going to talk through this in detail now because I'm running out of time, but basically one of the key assumptions is that the clinics are receptive to this expanded role. We had a number of physicians who were really upset about mental health integration in primary care practice. And they basically said, you're just trying to make us psychiatrists on the cheap. That was not the case. And some of those people who were most resistant to the implementation are now the biggest advocates because they can see the impact of holistically treating their patients, not just treating their medical conditions, but treating their mental health and their medical conditions simultaneously. We also note that, for instance, in our diabetes registry, 2/3 of the diabetics in our registry also have a comorbidity of depression. And we found that by treating both their depression and their diabetes simultaneously, patients are more compliant with care, we're better able to control their hemoglobin A1C and their diabetes. So it's really been an advantage in many different kinds of ways. The third example has to do with reducing unnecessary induction of early labor as an improvement target. And many of you know, I know in the United States there's a Strong Start initiative by the March of Dimes. And for those people who have elective deliveries prior to 39 weeks, there are huge disadvantages in terms of brain development to the fetus, in terms of other health outcomes and sequelae associated with those neonates who are electively delivered early. And so basically, and again, I'm not going to spend a lot of time on this example either because of the time, but I will just make a few important points. One is that we were looking to reduce the variation in the process. And Intermountain was able to reduce elective deliveries prior to 39 weeks from 28% to under 2% in a very short period of time. It was about 6 months. The biggest driver in that is putting a hard stop on scheduling. So if there's a way that your scheduling system talks to your electronic medical record and you can build in a hard stop so that people can't schedule elective deliveries prior to 39 weeks that are not clinically advisable, that had the biggest impact on that improvement. And what we were able to show in this particular example is that we were able to very conservatively estimate a savings of about $3,700 US dollars. And it would increase our capacity for deliveries to about 1,500 more deliveries a year. So we saw in that single year over a $5 million savings. And again, this has persisted over time, and we're now working through a hospital engagement network with 107 hospitals across the United States to see very similar kinds of savings across the country. One of the assumptions is that you have a high birth rate. Utah, in the state of Utah, largely because of the religious influence and the practices of the community, has a very high birth rate. So if you're in a country that doesn't have a high birth rate, you're probably not going to realize the same level of savings. But this is just a simple population estimate that we used. And again, as in all three of the examples, I've tried to give you suggestions about how you could further the analysis with more time, more in-depth investigation, if you have that. So, Kathy, I think you're up now.
So we kind of started at a very high level. Lucy took you down to show you how this kind of works on the ground with some a lot of detail behind it and how it works in individual and specific cases. And we really need to think about, I'm going to take you back up again. In the U.S., we talk about dark green and light green dollars. And this is again from our financial analyst that we worked with at Kaiser Permanente, and she did the analysis that I referred to earlier with the pneumonia patients. And finally, she said, you know, here's a way we can think about it. For it to be a dark green dollar in finance, I need to be able to take it out of somebody's budget somewhere. It needs to go away. And that helped us as clinicians, as we were working through this, to think about how are we actually going to get from light green to dark green dollars. Excuse me. So you see a couple of specific examples. A lot of the work we do is really better care for the patients, faster care, those sorts of things, but it falls on the light green side. So the dark green side, can we close a unit? Can we do less staff? Can we care for more patients in the same brick and mortar setting? What are those things that really look in that way that we can actually use? Excuse me, we haven't talked about quality, but I want you to think this through. For each of your projects, you need to have a quality measure that you're following to make sure that while you're making all these changes, there is not a way that you're harming quality. So we wanted to think about how you classify your projects. Is it something about harm? Is it something about efficiency? Or is it something about just supplies and supply chain and that sort of thing? The further you get away from the patient, the less likely you're going to harm the patient. But you always need to be thinking about that and building that into your model. Excuse me. And finally, we know it's not one project that's going to get us where we need to go. So this is a template that helps you think about projects and how they roll up together for savings.
Great, guys. Thank you very much indeed. Look, I did tease you about saving money and improving quality. I think that was pretty good, so thank you very much indeed. I was interested in a couple of bits that you said. Now, I couldn't see when you asked people what their background was, so let me ask again. Who are the managers here? Any managers? Great stuff. I love the bit, guys, where they said that we clinicians think that you guys have all the money and won't share it with us. I really love that bit. I mean, that is a real mindset to get across, isn't it? It really is difficult. But there was another thing you said that resonated very interestingly with what Ruth said this morning. When Ruth was talking this morning, she was saying, you know, that some stroke physicians had to oversee the downgrading of their unit for the improvement of some other unit. Now, you used a word that a clinician might find a bit discordant, and that was you were talking about reducing waste. How many clinicians here think that their work is waste? Now, try to get that message across. That is a really difficult message. So thank you very much. Those are really interesting things. Okay, how are we getting on Twitter? I see Teresa and VG have some messages here from Twitter. Teresa, do you want to tell us a little bit about them?
A bit like you're saying. Does this work? Yeah. That clinicians think there is all this money. I think that point has come over. And they can't get what they need for services. And there's a slight lack of trust between the two, which needs to be built. Clinicians can also see where money can be saved, and the financiers need to tap into that much more than they do. And that clinicians should keep talking to the financiers and understand better the requirement, so that they understand better the requirement needs for services. There was another suggestion that shadowing would be key to understanding on both sides. So there's a two-way process that clinicians shadow financiers and vice versa.
Teresa, let me hold you there because we've lots of different things. Let me as a clinician get these guys to answer that, okay? All these managers of all this money, these guys are hanging on to the money. They won't release it for us to do really valuable work. How did you persuade your clinicians?
Is this working? So I should tell you that I was a financial planner for a major health system in Chapel Hill, North Carolina, another state in the United States, and now I'm a quality improvement person at a major health system in the United States. And I have had quality improvement people, clinicians, stand in front of me and say, you want to kill babies because you're going to do this. But I can tell you that we all have the same objective in mind. And when you bring together people from different disciplines, whether it's finance, clinicians, administrators, researchers, understanding that goal alignment, that everybody wants to provide the best care possible to patients. In the supply chain area at Intermountain Healthcare, our expert person there has saved over $250 million. He assigned somebody to work with those clinical teams, and he says, don't tell me the cheapest product or device that you could use in a surgical procedure. Tell me what the best one is. Then let me go negotiate. But what you need to do as surgeons is to reduce that inventory. Instead of having 50 different devices available, you might have 5 different devices available. So the clinicians make those clinically relevant decisions, and the finance people support that, but they're working towards the same end and objective. And I think that appreciation and trust is really key.
So I'm the clinician, so I will add a couple things about how clinicians, remember I said to choose the right people. There are financial analysts who will not ever probably be able to think this way, and there are clinicians who may not be able to think this way, but may get there over time. The people you want to choose are the people that say, why are we doing this? And why do we do this? And this gets in my way. And because I don't have this when I need it, or if I only had this, I wouldn't need to admit this patient. Those are the people you want to think about, because they think about holistic methods of care, and they think about ways that they could be more efficient in their day-to-day work. And if you can help them tell you how they could be more efficient, my guess is there's waste there, there's dollars there, and if you can make that work and put a financial model with it, there's money to be gained and reduced waste in the system.
Great, thank you very much, guys. Now let's open it up to the floor. I think I saw a hand up there. We have a mic. Any questions here for the team? Somebody taking down their hand again. So Teresa, you're back on again. Do you want to reflect on some of the Twitter comments?
Well, we've got 2 questions that have come through. One is that finance people never see the money that quality people identify. Could this be because some are tangible but unbankable?
Yes. The interesting thing about this is, clinicians kind of think we can save all this money if we could do it this way. And financial people say, well, you said you were going to do that and we don't see any money. So there's 2 issues to that. One is the light green and the dark green dollars that we talked about. So how are you actually going to see the money? The second issue is, how do you identify the patient population that you're going to work with? Unless clinicians and financial analysts agree together what that patient population is, they may be going at it in 2 very different ways. And they may understand the patients very differently, or they may not even be measuring the same things. That's why it's key to start from the beginning, to understand what you're going to do, to understand what you think the results are going to be, both clinically and financially, and to work together on a daily, weekly basis to see if what you predict is actually happening in your system.
Yeah, and if I could just add, it gets a little more complex too. So in many cases, in the absence of having a financial person directly be part of the team, that's one way to make the numbers believable to the finance people if they help you generate that data. But when a clinical team develops a cost model in the absence of that perspective, the question you need to ask is, who saves the money? So the delivery system may actually, and I gave you an example with the CPAP example, where the delivery system actually lost money. The savings in that example went to the health plans and it went to society. It did not go to the delivery system. So that would be an example where the clinicians could demonstrate that they saved money, but who did they save money for? And so that's an important question to ask when you do these analyses as well.
Super. Any reflections on this? Any questions now for Lucy and Kathy? there's a question at the very back, Fiji. You'll have to go to the very, very back. In the meantime, Teresa, do you want to take another Twitter question? Because Fiji's jogging as fast as she can down to the back of the hall.
There's one more question here. That finance don't see the money that quality improvement saves. How can we change this? And does it require more communication?
Put finance people on your team, and yes, more communication.
Yes, I agree. And the example I discussed about the pneumonia, the clinical people would have gone at that a completely different way, but because they had finance on the team and the financial analyst was willing to sit with them and listen to what they were describing and to build the financial model that met the way they were describing the patients, they worked together till they both agreed, and then they were able to see the savings. Both saw them at the same time.
Thank you. You mentioned about not being able to see the savings maybe until they were further down the line. Could you also comment about the notion of a false economy, where something might appear to be a saving in one setting, but will actually incur further costs for another setting, maybe even in the same organization?
I think either of us could take that, and we're running short on time. It's a great question. That's why you need to be really careful where the edges of your system are that you're describing. In the example I gave you and the example Lucy gave you, the edges were completely around the whole system. But if you're doing something in perhaps a small segment of the system that's incurring additional costs in another, you may not be saving money. So you need to be very careful about what the project is, what the scope of it is, and where the edges of it are, and where the downstream effects might be.
And just to add on to that, so in the report that I referred to, they talked about this issue of you have to look across the whole sort of patient pathway or experience. And I think the MHI example that I gave you, where you could see what happened, what was the impact on emergency room use, what was the impact on inpatient services, outpatient services, pharmaceutical drug use. So you can actually see those differences, and that was why it was important to look at overall total cost, but with the understanding it's going to impact those budgets across that care continuum. And so you need leadership to understand those implications in terms of what are going to be the variances in those budgets because of the improvement that's being put forward at an organizational level.
Thank you. Now, have we any further questions from the audience? There's a question. There's a question on the way, and then we have another. We'll take yours, the very final question.
I just want to mention that what you've said about the involvement of clinicians and talking together with your finance people, it is extremely important. In my country, it has happened several times now that there was a mass purchase of equipment and clinicians were actually asked what they needed. But when they made recommendations on what models would be suitable, that was ignored by the financial people. And in the end, the majority of this equipment was useless because some of parts of the equipment wasn't purchased, and now the money was spent for that financial year, so it had to wait till the next year to be budgeted for. So it's very important, but to have your clinicians involved in not only what equipment, but what would be suitable equipment for them to work with.
Thank you.
Thank you very much for that observation. You're going to have to jog up at the front, the fittest person in the building. Thank you very much, Ricky.
While you're jogging, I might just add, we talk a lot about bringing finance and quality or clinicians together, but don't forget the researchers who are helping you innovate. They're another important component on the team.
G'day, I'm Isaac Seidel from Australia. I'm currently living in America, and one of my reflections on the American healthcare system, and I'm checking for thunder and lightning first, is that it's very hard to find a primary care physician, and that I'm forever having to refer myself to the appropriate specialty, and thankfully I don't have to do that very often. So my comment goes to the discussion about mental health management and how it seems revolutionary in America to treat mild to moderate mental health in primary care, whereas this is something that as an Australian GP, it's common business. 80% of mental health is treated by general practitioners in Australia, and I'm sure in the UK it's something very similar to that. GPs are trained and credentialed to do mental health in both of those countries and probably many others. So my comment and question, I guess, is to seek your reflection on that and whether any of that work is in a way reinventing the wheel that was created in systems that have proper general practitioners such as the UK and Australia.
Yeah. There are examples where it is not as necessary, where there isn't that fragmentation of care. The United States has historically really carved out mental health services, which has been a problem, so this is a solution to that problem. I know that our teams have worked with groups in Argentina, Singapore, so we've worked with people around the globe in terms of adopting the mental health integration model. So in some places it has values, in other it doesn't. I would suggest to you, if you have time tomorrow, to go to session H2, where Pascal's going to talk in much more depth about the impact on primary care and the value of integrating those teams. And it's not just having psychologists and psychiatrists available in the clinics, but a team-based approach, which then doesn't put everything on the burden of the primary care physician, that team actually complements that so that you can see increased productivity and decreased waste and waiting times for patients.
Okay, thank you very much. We'll finish there. Lucy and Kathy, thank you very much. That was absolutely super.